all uveitis, and it's very easy to treat. Only you can use the topical steroid and cycloplegic and you can get rid of it. But we'll see that how the things can be little different. So here in this first slide, you can see what I have done. I have analyzed all the retrospective studies, mainly from the institute and also from the one or two from the other institute that actually analyze the various causes of uveitis. And what we see in anterior uveitis, the demographic profile that emerge out, that it's the most common of subtypes of 35 to 57% of all cases. 80% of the patients are male and 19 to 60 years of age group are involved, and mostly they are unilateral, and the most common among this anterior uveitis is acute and non-granulomatous anterior uveitis. So if you analyze the cause of this anterior uveitis in Indian scenario, we see that majority of them remain idiopathic. Among the identifiable causes, the HLA-B27 associated uveitis is very common, followed by the tuberculosis, then the viral, Fuchs and sarcoidosis. Now what we'll see here, that sometimes we need to spot the zebra in the heart, because we keep seeing the common uveitis and suddenly the presentation can be different. So we'll see how it can be. For example, this HLA-B27, what we know that this is commonly young males are involved. It's recurrent in nature. It is almost always unilateral, but keeps on alternating from one eye to another. And we see a triad of pain, redness and photophobia and high fibrin content in the anterior chamber or with hypopyon. So this is our knowledge. We'll see here another case, a 23-year-old male presented with ocular pain, diminution of vision, and diagnosed elsewhere as endogenous endophthalmitis. Now, why endogenous endophthalmitis, and the patient was advised vitrectomy? Because you can see there was a lot of inflammation in the anterior chamber, and similarly you can't see the fundus because of significant vitreous haze. So the patient, when we took history, the patient told us that he had a similar attack of redness, pain in past, and also the documentation showed that he has been treated with topical steroid and cycloplegic earlier. So now here we did the urine culture, blood culture, everything was negative, syphilis, sarcoid and TB workup was negative, but HLA-B27 was positive. The patient was treated aggressively with IVMP, and high dose of oral steroid followed by methotrexate was given, and you can see the response after a course of pulse corticosteroid. So this is, we are dealing with anterior uveitis with anterior uveitis. We have analyzed 255 cases of HLA-B27 positive uveitis, and we realized there is a subset of uveitis, almost 4%, which can present with anterior chamber inflammation and significant inflammation in the vitreous also. So you need to differentiate that, and you have to understand that, because if you do vitrectomy in such cases, for example, this is another vitrectomized eye from another hospital, and you can see the vitrectomy was done nice, but eventually everything was successful, but eventually the patient went to thusical eye. So this is another HLA-B27 uveitis, is 34-year-old lady, and third attack in a year, mainly, though the patient was on methotrexate, little subnominal dose, and you can see here the lady presented with 4 mm of mercury intraocular pressure, and you can see here it was a case of actually exudative retinal detachment. So sometimes you can actually come across this kind of unique presenting feature, and you have to be careful decoding them. So this is another literature on how the anterior uveitis can be so severe that it can present with serous retinal detachment and choroidal detachment also. Also, you have to understand this kind of picture can have the changing phase, not only this animal, but sometimes the uveitis also can change phase like this. So most commonly you see that overlap of granulomatous and non-granulomatous. For example, sarcoid is a classical example, though it can present with granulomatous uveitis, and sometimes it can present with non-granulomatous. Similarly, the viral anterior uveitis, it can run a chronic course also, or it can come with a very hyperacuate course also. So sometimes you need to spot the cat in the shadow, like sometimes we overlook the anterior uveitis. The classical example is Fuchs uveitis, most underdiagnosed and overtreated cases of uveitis. So the diagnosis actually depends on you can see the loss of fine pattern of the iris. You can't see the heterochromia, which is very evident in people with Western people. So in darker individuals, you can't appreciate that heterochromia. So you have to look for the loss of fine iris pattern, KPs and various other findings. So another anterior uveitis is that tubulointerstitial nephritis in uveitis. So this is seen in children, and sometimes you can see that by the time the patient comes to ophthalmologist, the renal parameter becomes normal. So that's why you tend to miss these cases. And sometimes you need to find out that the anterior uveitis in ship's clothing, like uncommon presentation in common anterior uveitis. For example, you see, you have to understand whenever you treat a case of anterior uveitis in children, you have to make sure that you have ruled out JIA, because JIA can be a notorious run a chronic course, and you need a rheumatologist's help to treat that. So don't treat a case of anterior uveitis only with topical steroid or cycloplegic. So what are the features of JIA? The ABC, I tell that. The A, it is often asymptomatic, white eye uveitis. It can be bilateral, often presents with band-shaped keratopathy, and run a chronic course. And so what are the tips that you have to, any case of anterior uveitis in children, you have to rule out. You have to take the history about the joint pain, and you have to send the patient to rheumatologists to build a bond with them and keep treating these children for a longer time. And you have to rely on the systemic therapy. You have to start the patient on immunosuppressive and various other conditions. And you have to, one most important, not only for the JIA patient, for every patient of anterior uveitis, you have to check the intraocular pressure regularly. So this is another patient of a 5-year-old child. You can see here, looks like an anterior uveitis, lot of exudate-like material in the anterior chamber. And when we did the UBM, you can see here there was moderately reflective seed-like echoes, more inferiorly. So these patients, when we did investigation, everything was normal limit. The AC tap was negative for the herpetic viruses also. But when we did the cytology, it showed the malignant cells. So it was a case of diffuse anterior infiltrating retinoblastoma. So sometimes this kind of condition can present with anterior uveitis, and if you miss that, then you can actually miss the child also. So another patient, you see here a 6-year-old female child, a case of acute lymphoblastic leukemia on remission. The child was doing well, suddenly presented with a hypopyon uveitis like this, and that's the time we realized that the child is having a relapse of the malignancy. And we did a AC tap, and the aqueous collected from the AC tap showed that these are not the inflammatory cells, these are the lymphoblastic cells which has come to the anterior chamber. So in leukemia patients, sometimes you can get a hypopyon. You have to make sure that these are not the inflammatory cells, or whether these are lymphoblastic cells or not. To conclude, don't always take anterior uveitis very easy one, and try to treat them empirically. And one should always should not wait for 3 attacks of non-granulomatous uveitis in every patient for starting the treatment, because sometimes the HLA-B27 uveitis, you can pick them up early, and you can explain them the recurrent nature of the inflammation, and you can actually help them to reduce the recurrence by starting the early immunosuppressive agents. And all cases of needs to go through extensive evaluation before leveling them as a idiopathic. Thank you.
Thank you, Dr. Partho, for the elegant and lucid presentation. We'll have questions. Believe me, we'll have the two-way communication.